Hey there guys, welcome back. We're going through our anesthesia and CPR module, and now we're going to just go on to the Armamentarium. This is basically the tools of the trade for dentists all around the world, students alike. So we need to get used to this as soon as we can, make sure that our patients are numb during the procedure. So we're going to be using a book that is assigned to us by the university. It's a very good one. It's called The Handbook of Local Anesthesia by Stanley F. Malamed, I guess the name is, 6th edition. And we're going to be covering the following topics today, if I could just highlight them for you. We're going to go through the syringe, the needle, the cartridge. Those are the main things. There's a few sort of safety precautions that we'll go into as well, just to help us out as we go along. So, to begin, we'll just look at the syringe itself. The syringe is actually that shiny metal thing that dentists plonk into your mouth to make sure that you don't feel a thing. Some people think the syringe is actually the needle part, but the syringe is a big fat thing. The needle is the needle. So we want to make sure that it is durable, as it says here, and withstand repeated sterilization. We want to be able to use it again and again, reducing our costs, and also it's better for the environment to ensure that we're doing this. It's lightweight, simple to use, and should basically allow for effective aspiration. So what is aspiration? This is a very important thing for dentists to implement. Aspiration is creating a negative pressure within the syringe itself by pulling back on the thumb ring, and that allows us to know whether we have, in fact, reached the correct region for numbing the tooth, or whether we're unfortunately in a blood vessel. We don't want to be doing that. We don't want to be in a blood vessel and then pumping anesthesia into it. So the negative pressure, or the aspiration, allows us to see whether there's a bit of blood that's gone back into the syringe through that little glass container known as the cartridge or the carpule. If that blood is present, that means that we're in the wrong place. Usually we need to come out by 0.5 millimeter to 1 millimeter max. Aspirate again to have a look whether we are at the right place now or not, or still in the blood vessel. And so long as we're not, then we can carry on with the procedure. This just makes sure that we're doing our due diligence on our patients to ensure their safety. If we just read from this point here, where it says the needle is attached to the barrel of the syringe, the needle adapter, which is pretty common sense. The needle then passes into the barrel, where it penetrates the diaphragm, and then the adapter screw is removable and sometimes discarded inadvertently along with the disposable needle, which is something we'll get onto in just a second. So here we're just going to have a look at this diagram over here and here. So diagram A shows the main parts of the syringe itself. I'll just highlight them in red. We have the thumb ring, which is obviously where our thumb sits. It allows us to pull back for that aspiration and obviously push through, should I say, positive pressure to actually administer the anesthetic solution. We've got the finger grip, which is where our fingers obviously sit, like my fingers are on this pen now, my thumb there. The piston is this long bar here with a harpoon at the end of it. Then we've got the barrel itself, which is the outside part, this bit here, and then the needle adapter. So this is something that was mentioned earlier. When we are screwing the needle on, when we take it off, we have to unscrew it, and sometimes this unscrews with it, we'll throw it away. And this is a disassembled view of the syringe in diagram B. What we do need to ensure is that the syringe we're using is the metallic type. They are auto-cavable, so they are able to be disinfected and reused again and again. One of the key things that we need to do as practitioners is to ensure that when we are using the syringe is to always hold it with the palm up. Now the palm up allows us to have greater control. It doesn't lift our elbows and put us into uncomfortable positions. So the next point that we're going to go into is the needle itself, gauge of the needle, which is essentially the diameter of the needle itself. Other things to know is obviously the different parts of the needle itself. So we've got here the bevel, the shaft, the hub, and the cartridge penetrating end. If I was to draw that for you very badly, it would look like this. That's the needle itself, and then we've got the hub, and then we've got a point here, which is the cartridge penetrating end. This part here, if we want to break it down, is the bevel, which is angled slightly which obviously provides a point for insertion. And also this bevel should always be facing the bone. If that's the bone, it should be alongside the bone, so it sits nicely over the bone, doesn't cause any drag on the tissues or any form of injury to the patient. We've then got the shaft of the needle itself, this main bit here, the hub. The hub will actually have, I'll use this time quickly to draw this actually. The hub will usually have a triangle on it. Wrong colour, yeah. You usually have a triangle on it like this, which will show the direction of the bevel. So you know where the bevel is without having to check. And another way to check where the bevel is obviously to apply some positive pressure, see the solution go through, and a drop will appear on the side where the bevel is. Just good practice to know where that is. And then you've got the penetrating end of the needle itself that will go into the cartridge. Sit here, we'll pierce that, then obviously you get your positive pressure through. And here's a much better defined version of the drawing I was trying to make. As you can see here, this little tip here at the corner, that is the bevel. This whole length here is the shaft. We've got the hub, which is this bit here. I kind of missed out the syringe adapter. That obviously needs to sit on the syringe itself. You need to tighten that on. And then you've got the cartridge penetrating in here. So one thing that we need to know is deflection. What is deflection? It's essentially when the needle is going in, and I'll try to draw this, it should be following this line here. So as you can see from the needle, should be going to this target point here, right? I mean, that's a bit off, but you get the picture. It's meant to be hitting this target point here. But because this needle in particular is quite flimsy, the one on the left here, right? It's deflected off away from the region that we want to be hitting. What is this due to? It's actually typically done due to the gauge, or in this case, it actually says here 30. 30 years would be a higher number, which means it will be a thinner needle, which means once it penetrates the tissue, it's more likely to move and curve and do all sorts of things. So the advantages and disadvantages of a higher gauge is advantage would be it's less painful because there's less penetration. The disadvantage would, of course, be it deflects more. So these are things to just bear in mind when we are practicing. As mentioned earlier, we should have this grip here and palm up. Now the length is very important as well. It's very, very important in fact. So we have three types of needles. So we have the ultra short needle, which is here, only available in a 30 gauge, so that's super thin, super small. And this will be 10 millimeters in length. Very, very small. All infiltrations are done usually either by a short needle or an extra short. This provides a lot more control for us. Obviously, being with a larger gauge will mean it'll be slightly less painful. However, people say that studies show that people will find it almost impossible, if not impossible, to differentiate between a 25 gauge and a 30 gauge, for example. The length of a short needle is between 20 and 25 millimeters from hub to tip, and then a standard long needle is 32. But just remember the rule of 10, 20, 30 for ultra short, short and long. And this really is 32 to 38 millimeters. Either one of those usually. This is just the best way to remember it is at 10, 20 and 30, around those regions, which one's which. I'd ask in an exam, for example. Now, how do we care for and handle our needles? Obviously, being a sharp object that can cause injury and spread infection, we have to ensure that we dispose of them correctly. So we're going to make sure that we use a sharps container to properly dispose of any needles. I mean, if you're thinking of needles, lancets or scalpels, cartridges as well, they're made of glass. So we need to be putting them away into the sharps container. In our university, they are yellow boxes, highlighted in red. You cannot miss them. For the sake of yourself, your patient and others and staff members and all the rest of it, have to ensure that we are putting them in the right places. So sharps container is extremely important for us to know. The one hand or the scoop technique is also imperative to know. We do not want to be picking up a needle cap and putting the needle back on after we're done with it. It's dangerous and it can lead to a needle prick injury, which is not fun for anyone. So while the needle cap is on a hard surface, we're done with the needle, we want to recap it, we just scoop it up and then plonk it back on. After that, of course, we want to unscrew it carefully, making sure that we're not removing the needle adapter. and then disposing of it carefully into the sharps container. Now, the cartridge that we are most familiar with is a 1.8 milliliter cartridge, and it will be made of a glass container, cylindrical glass tube right here. You've got the stopper, the bung, which is on the back end of it, the aluminium cap, which is at the front end of it, and that will have its own diaphragm, which needs to be pierced. These are the things that we mentioned earlier. This one here is a 1.8, I'll underline that. It says 1.7, but that's the one we're most used to. And then everything will be written here on the actual cartridge itself. So over here, we've got 2% of the solution itself. And then we've got almost a brand name of it, which is lidocaine in this case. And just here underneath, you'll see it says lidocaine, which is essentially what it's made of, or what the key ingredient within that is. And then we've got epinephrine here, which is the vasoconstrictor, and then some more information underneath it as well, which is obviously we can't see it from here. Just to familiarize ourselves, this is obviously the aluminium cap and the rubber diaphragm within that the needle will be inserting itself into. And then got the silicone rubber plunger where the harpoon goes into, and then in between is basically where the solution lies, and that's what we want to administer to our patients. And just to cover what really is inside a cartridge of anesthesia, we've got the local anesthetic drug itself, so in this case it's lidocaine. We've got sodium chloride for the isotonicity of the solution, as it says here. We've got sterile water to provide volume, so you want to obviously have something for all of that suspension to be contained within. The vasopressor, which is the epinephrine. Why this is important is the duration of the anesthesia is increased by doing so, because we are actually reducing the amount of blood in that area. So when we vasoconstrict the vessels around that the zone that we're anesthetizing, we're making sure that basically just stays there, it doesn't get carried away by the blood, which is one of the main things. At the same time, it doubles up by being a bloodless field. So what we don't want to be doing is working on a tooth and loads of blood everywhere. If we're using vasoconstrictors or vasopressors, it just means there's a lot less blood in that area when we're working, which gives us more of a visible bloodless field to work in. So it's very helpful for us as dentists. And then you've got an antioxidant here, sodium metabisulfite, and then some old stuff that we don't use anymore and we're not going to talk about. One of the questions we had in one of our quizzes was how to work out the milligrams per cartridge. Then it went on to a further part, which was how many milligrams of the solution could a certain patient have who weighs a certain amount. So what we need to know is that 1% of solution is always equal to 10 milligrams per milliliter. That's the main thing that we need to know. 1% is equal to that. Therefore, by this mean 5% would equal 50, as an example, per milliliter. Now, if we were to then find out how many milligrams there are of that solution within a 1.8 milliliter cartridge, which is the ones that we're using at the moment, we just multiply 1.8, that's the milliliters, by the grammage, which is 10, which is equal to 18 milligrams. And if somebody is allowed to have 185 milligrams of a solution, we just 18, 185, 185 divided by 18 will be around 10 cartridges of that solution they're allowed to have. So you can mess around with the figures. It's pretty simple once you get your head around it, but that's a very important question that was asked to us. And again, it says here on care and handling, just to ensure that we're putting that away in the sharps container and doing our bit to ensure that there's no issues for anybody who's disposing of it. And that kind of brings me on to my final point, that when we're handling our syringes and our needles around patients, kind of keep that visual check, as low as possible, that patients are going to kind of gleam over and try to look at what's about to go in, and you preparing your syringe and adding the needle to it, etc. Very daunting for them. You just want to make sure that we're kind of doing it in an area where they can't see it. We turn our back to them or do it behind them, so that they really don't catch a look of it until it's too late and they're numb. So that's how we want to go about doing it, and making sure that everyone's happy as we go along and everyone's safe, and that's the main thing. So I hope you enjoyed this video. I hope it shed some light on the tools of the trade for dentists, and so hopefully tie on with the rest of the videos that we're doing. Take care. See you guys soon. Bye bye.